Yeah, thank you. So good evening, everybody. I'm here. I'm very excited here. For this sixth session, which is the from ASG Academic Cell and ASG Eye Hospitals are presenting this wonderful webinar here on Macular Hole Decoded. And the primary speaker will be Dr. Atul Dhawan, sir. And we have wonderful panelists with us from all over the world. And we have Dr. Vajinder and Dr. Ravi, that's me, who will be moderating, and I'll be presided over also by the ASG Academic Cell, which consists of Dr. Ganesh sir, Dr. Kaushik Tripathi sir, Dr. Mayank Sharma sir, and welcome to all the guests here, all the listeners, and uh, all the participants from the ophthalmology world. So our first panelist is Dr. Avakian Flora, who is a postgraduate student in the S. Fyodorov Eye Microsurgery Federal State Institution. She's currently working, doing her PhD topic in the surgical treatment of idiopathic macular holes with the internal limiting membrane sparing for, like she just said, for the small and medium-sized holes. Welcome, ma'am, to this discussion and this wonderful webinar. Next, we have Dr. Larissa Yuri. She's a medical assistant at the ophthalmology emergency room at the HCFM USP University of Sao Paulo, Brazil. She also works as a VR surgeon and a cataract surgeon at the Santa Cruz Hospital, again in Sao Paulo, Brazil. She had also underwent her residency and fellowship in VR surgery at the hospital she's currently working in. Next, Dr. Vajinder will introduce the next panelist. And welcome, ma'am, to this webinar. Glad to have you here.
Thank you
Dr.
very
Vajinder.
much for the invite.
Ravi, can you please unshare your slides?
No, it's next slide, sir.
Okay, good evening, everyone. So I am welcoming you all on the behalf of ASG. And so our next panelist is Dr. Bartosz Bilinski. So he graduated from Jagiellonian University in Krakow, Poland. He finished his residency in USKNR in Lodz City. So he has gained experience in the hospital, ophthalmic ambulatory, and as an university teacher. Currently, he is working in Jason Blonia Clinic, Lodz City.
Good evening, everyone.
Welcome, sir. And our main speaker here is Dr. Atul Dhawan, sir. So Dr. Atul Dhawan, sir, after completing his MS from MLN Medical College, he did his vitreoretinal fellowship in Dr. Agarwal's Eye Hospital, Chennai. So he worked as a senior vitreoretinal consultant at Agarwal till Dr. Agarwal Eye Hospital till 2022. After that, he has presented and attended various national and international conferences. He started the Harvard WhatsApp group. In that group, we have a lot of senior vitreoretina surgeons, and where we can share our experience as well as our knowledge. And he has a great interest in the macular surgeries, and also he is a reviewer for AIOS. Currently, he is working as a senior vitreoretina consultant at ASG Eye Hospital, Kanpur. Now, I will request Dr. Atul Dhawan, sir, to kindly start the today's class. Please, sir.
Dr. Atul, you can unmute yourself.
Can you see my slides?
Yeah. It's
Okay.
visible.
Okay, thank you. First of all, I would like to say thank you to my ASG academic self, who has given me the opportunity to present something where many of the stalwarts from all over the world have already given the lecture. So today I am going to talk about macular hole. And in the next half an hour, we will discuss about almost all the aspects of macular hole. So before going into the macular hole and macular hole surgery, we will revise few terms. And these few terms I'll repeat again and again during the next half an hour. So what is macula and what is the fovea? So macula, on the basis of OCT, the macula is consists of 10 layers. But just for the revision, it starts from the RP, then ISOS junction. After that, external limiting membrane, which is formed by the Muller cells. After that, outer nuclear layer is present. Outer nuclear layer is nothing. It is the cell bodies of the photoreceptor cell. After this, Henle's nerve fiber layer. Henle nerve fiber layer is the axons of photoreceptor cell. Now, these axons synapse with the dendrites of bipolar cell at outer plexiform layer. So, outer nuclear layer axon form the synapse at the outer plexiform layer with the dendrites of bipolar cell. After this, the axon of bipolar cell form the connection with the ganglion cell layer dendrites, and it is called as inner plexiform layer. The axons of ganglion cell layer from the nerve fiber layer, and the last one is the internal limiting membrane, which is the foot plate of the Muller cell. So these are the 10 layers, but these 10 layers are not present in the fovea, which is having the highest visual acuity. The only layers which are having at the macula is, first one is the internal limiting membrane. The second one is the outer nuclear layer. Remember, there is no axons of outer nuclear layer in fovea. So internal limiting membrane, then outer nuclear layer, external limiting membrane, and fourth one is the RP. This is the main anatomy of the fovea and the fovea. The second term I am going to use is the posterior vitreous detachment. We all are talking about posterior vitreous detachment day in and out. So what is normal posterior vitreous detachment? The vitreous is consist of two parts. One is the central gel, the other one is the vitreous cortex. The central gel, if there is liquefaction of the central vitreous gel and detachment of the vitreous cortex at the same time, means vitreous liquefaction and vitreous cortex separation at the same time from the retina, it is called as normal posterior vitreous detachment. Now, what is anomalous posterior vitreous detachment? Anomalous means away from the normal. Away from the normal means if the gel liquefaction outpaces the detachment of vitreous cortex, means liquefaction is there, but still the attachment of the posterior vitreous cortex with the ILM is there, then it causes anomalous posterior vitreous detachment. The second one is if vitreous cortex adhere to the ILM with abnormal adhesion, then also it will cause the traction. So it is also called as anomalous posterior vitreous detachment. In few cases, the combination of both are present. This anomalous posterior vitreous detachment is the reason of all the vitreomacular interface disorder. In nutshell, 5 types of vitreoretinal macular interface disorders are there. One is vitreomacular adhesion, the second one is vitreomacular traction, third is lamellar macular hole, fourth is full thickness macular hole, fifth is pseudo hole. Nothing to mug up, it's very simple. If posterior vitreous cortex is attached at the ILM, but there is no morphological change in the retina, it is only adhesion. If posterior vitreous cortex is attached to the retina and it is causing the morphological change, then it is vitreomacular traction. If it is causing the half thickness macular hole, it is called as lamellar macular hole. If it is causing the full thickness macular hole, means the hole is present from the ILM till the RP, then it is called as full thickness macular hole. The fifth one is macular pseudo hole. In macular pseudo hole, the ERM formation is there over the surface of the ILM. This ERM causes the contraction towards the center of the fovea. This is called as centripetal movement. The two terms I will take very often during this class. One is centripetal force, the other one is centrifugal force. Centripetal means towards the center and centrifugal means away from the center. So in the case of macular pseudo hole, the ERM forms and it causes the force towards the center of the fovea, which causes the steepening of the wall of the vertical wall of the foveola. And on slit lamp examination, you will feel it's like a hole, but on OCT examination, there is no hole, just thickening of the macula is there. Now we have cleared the basic. We are moving into the macular hole part. So we will take this macular hole class in a question answer session for the better understanding. This class in this lecture, many of the parts are by the work of Dr. Brinjman. Dr. Andreas Brinjman is from Germany, and he has done a lot of work on fovea and the foveola. And he has almost 273 index publication on fovea and the foveola. So something new I am going to tell you in the next few slides. First is, we are seeing this photograph day in and day out. This is the normal retina OCT, but whether this is the resting stage of fovea or not, the answer is a big no. It is not the resting stage of the fovea. Here you can see there are two types of forces acting over the foveola. One is centripetal force, the other one is the centrifugal force. In the center, you will see 4 layers are there, as I have told you before also, ILM, internal outer nuclear layer, ELM, and the RPE. But Dr. Brinjman has told there are 2 types of spatial Muller cells are there in the retina. One is foveal cone Muller cells, which is at the foveola. The other one is the foveal wall Muller cells, which is away from the foveola. So the foveal cone Muller cells are having 2 parts. One is this is horizontal part. The other one is this stalk. The foveal wall Muller cell are away from the foveola. So there is a continuous tug of war going on at this center. This foveal cone Muller cells are pulling the retina towards the center of the fovea by centripetal force, and it is opposed by 3 forces. One force is by Henle nerve fiber layer, the second force by the nerve fiber layer of the ganglion cell, the third force by, which is not here, the partial detachment of the vitreous, that is causing the anterior posterior force towards the center of the eye. So one force centrifugal and 3 forces, one force is centripetal, 3 forces are centrifugal. In the normal U-shaped fovea, the centripetal force is more than the centrifugal forces. That's why the fovea is U-shaped. Now, how the full thickness macular hole form? The full thickness macular hole form when there is partial separation of the posterior vitreous cortex, which pulls the foveal cone Muller cell towards the center of the cavity. This causes the enlargement of this cavity, which is called as foveal pseudocyst. This causes, and there is formation of cystoid spaces in the Henle nerve fiber layer and the outer nuclear layer. After some time, this force, this anterior posterior force is so strong that there is a full thickness macular hole formation is there. So at this time, the centrifugal forces are more than the centripetal force. That's why full thickness macular hole form. Now, if there is any cut in the body, then body will seal it automatically. Then why it is not going in the retina? It is going in the retina also. And it is called as spontaneous closure of the macular hole. So many cases people have published and so many case series are there in which they have reported 4 to 11% of the cases of the macular hole, they closes spontaneously. How they close? One is when there is separation of the foveal cone molar cell, then still some foveal cone molar cell are present at the inner margin of the full thickness macular hole. Now, foveal wall molar cell are present away from this center of the hole. As soon as the hole form, these foveal wall molar cells, they start concentric contraction. Concentric contraction means contraction towards the center of the fovea. This leads to approximation of these two edges. This is like a glue. Once they approximate, they form a bridge and hole close from inside. At this time, you can see the hole is still open from outside. So the basic theory is, because of the concentric contraction of foveal wall molar cell, there is movement of the full thickness wall towards the center and approximation and attachment of the foveal cone molar cell again. This leads to closure of the hole on the inner side. After some time, because of this concentric contraction, these foveal wall molar cell, they form a ring at the level of ELM around the photoreceptor. As they start concentric contraction, they pull the retina towards the center and they regenerate the ELM and displacement of the photoreceptor from periphery towards the center in this process, and this leads to the spontaneous closure of the macular hole. I'll show you two examples. This case, I have done the surgery in 2020. In this case, the radial keratotomy was done in 1995. The patient came in 2020. Surgery was done. On the first post-op week, everything was fine. Patient was from Dubai. Patient has gone, and after 1 or 2 months, the patient came with this macular hole. You can see there is full thickness macular hole plus cysts are there. These are the cystoid spaces because of this full thickness macular hole formation. This is a full thickness macular hole and it was small. So I thought, okay, I'll leave it like this. And after 1.5 months, I'll remove the oil. I'll do the ILM peeling and the hole will close. The patient came again after 3.5, after 1.5 months. You can see there is a spontaneous closure of the macular hole from inside. Still the hole was open. So I have removed the oil and I did nothing. The patient came again after 2 years of surgery. You can see U-shaped closure of the macular hole was there and all the layers were restored. In this case, the final visual acuity was 6.9. The second case is very unique. Only 4 cases reported till now in the literature, and we are writing this case report. This lady, high myopic, LASIK was done in 2011, 2015 RD was there, so we have done the surgery. In 2015, 2016, oil removal was there. 2020, she came, everything was normal. Vision was 6.6. 2021, you can see suddenly spontaneous opening of the central full thickness macular hole. At this time, some ERM was also there. The hole was very small. So I have decided, okay, I'll wait because I had a very good experience with the previous case. So I thought, okay, we will leave it and we will see this case. After 1 month, the minimal hole diameter was decreasing, but the cyst size were increasing. So again, I told the patient, wait and watch. Again, after 1 month, the patient came, the hole closed here from inside. Still the hole was open from the outside. I told the patient again from 6'9" became 6'6". I told, okay, we will just wait and watch. This is July month 2021. Now see, again October, again the hole opened. Again, I did nothing, just wait and watch. Every month she was coming. She was 6'9". She was not ready for the surgery. I was just giving Predfort and Dorsens because it is thinking that by drying up the macula, we can close the macular hole. You can see in the March, again, the hole was closed from inside in 2022. After that, I don't have any follow-up, but the hole was closed again, and the patient again become 6'9" also. So if the holes are closing spontaneously, why not all the holes close spontaneously? So there are 3 reasons. One is the hole is so large that approximation of the inner wall is not possible. The second one is centrifugal forces by ILM or ERM is strong enough. Then the centripetal force by the foveal wall Muller cell concentric contraction. The third is combination of both. So if the hole is large, the foveal wall Muller cell are not able to close it properly, or it is a combination of both, it will not close. The chances of spontaneous closure is high in holes less than 250 micron, not in large hole. So at this time, how can we help the retina as a best friend? We have 2 options. Either remove the tangential traction or close the hole artificially. How we can remove the tangential traction? One is by ILM pinning. The second one is by the macular massage. Hole closed by artificially by either by the ILM flap, amniotic membrane, or the retinal tissue. I will discuss only 3 things here: ILM peeling, macular massage, and ILM flap, because rest 3 I am not doing. Rest 2 I am not doing. So conventional macular hole surgery by 360-degree ILM peeling. So first of all, always understand ILM is 4 micron thick layer. It is very fragile. Hold it and deal it very gently. Always remember. Now, few things I am going to tell you how to hold the forceps during the ILM peeling. This is the wrong way. Don't hold the forceps in the vertical direction. You will not be able to see which tissue you are holding. And by this, you can hold the nerve fiber layer also. And by this, you can cause the iatrogenic trauma to the nerve fiber layer. You have to hold the forceps in an oblique direction. The second one is how to pinch the retina. Never pinch the retina in a single go. We have to peel the retina after 2 or 3 attempts. By this, we can loosen up the ILM. We can pinch the ILM after 2 or 3 attempts, because after 2 or 3 attempts, we can pinch it properly by loosening it up from the nerve fiber layer. Now this is ILM peeling, and it is without editing. I'll stop the video many times and I'll show you what is the reason of every step. So see here, I am using the left hand is my light pipe, right hand is my forceps. It is oblique in direction. I can see whatever I am pinching. The shadow of the forceps is going away from the pinching side. Making a very small a very small piece. Now see, I have tried here to hold the ILM from here. I was not successful. That's why I have gone here. I'll hold the ILM from here and I'll complete my peeling part. First of all, I made a big ILM flap. Now see here, I have touched a very small part of the nerve fiber layer. Now I am completing my peeling. Usually I peel from arcade to arcade. This looks small, so I'll augment this peeling. This forceps can hold only one membrane. You can see it is not able to hold the second membrane. Now again, I'll go back. I'll hold the ILM. Again, I'll go at the base. I'll make a small peel. Again, I'll go at the base, small peel. I'll pull tangentially. This video is without any editing. I am pulling away from the center, but not 90 degrees. It's around 45 degrees to make a big peel. Again and again, I am going towards the base to make this peeling in one go. Now the second is how to close the hole artificially. This is by the ILM flap, and I have developed a technique called as color visco assisted placement of the ILM flap. In ILM flap, 3 questions are there. The principle of ILM flap is, first of all, how much big ILM flap we want, how to make a flap, and how to keep the flap over the hole till the end of the surgery. We will discuss one by one. If we'll go our physics knowledge of 10th, 11th class, then we will find out if 2 glass plates are separated by a thin water, then to remove the glass plate, we have to apply some force F, which is directly proportional to the area of the contact. So if the area of contact is large, the force is more. In the ILM case, if our flap is large, the natural force which is required to remove this ILM flap from the retina is more if the flap is large. So we have to choose a large flap. Now the second question is how to make a proper flap. So I'll demonstrate here, then I'll demonstrate the surgery. These are 3 layers: RPE, neurosensory retina, and the ILM. Now, how to make a flap? Before making a flap, a imaginary line which is almost 200 degrees away from this macular hole, and we have to make small cuts in the circumferential direction. Just see, I am making an imaginary line. Why I am making 200 degrees? Because the vectorial forces towards the center, towards the disc, and the chances of displacement is less with the 200 degree ILM flap. Now I am connecting all the small pinch. Now how to place the flap over the hole? Just pull it from one side to other side, just paste it over the retina. Now, how to keep the flap over the hole till the last part of the surgery? If we will put some viscoelastic or some PFCL, then we can do it. I am using the viscoelastic, which is colored by the brilliant blue. So, by the main motive of the coloring is to take out the full viscoelastic, which is visible at the end of the surgery. How I am doing? I am putting the viscoelastic on the temporal bare part, then I am tilting the eye towards the disc, and I'll take out this viscoelastic at the end of the surgery. And in this process, it will iron out the flap over the retina. Now, this is cap technique. How to make viscoelastic visible? The answer is to color it. Just take low molecular weight viscoelastic and color it with a 1 drop of brilliant blue. This is 180-degree ILM flap, 550 micron. 7-8 years back, I have done this surgery. I am making the flap with the help of finish loop. Slowly and slowly, you have to separate the ILM from the nerve fiber layer and then place it over the hole and support it with the help of the colored viscoelastic. Do the fluid air exchange, take out the full viscoelastic at the end of the surgery by tilting the eye towards the disc. You can see U-shaped macular hole closure was there in this case. My result was in 2018, one of my fellow has done a thesis of 30 cases, and day 7, you can see no ELM regeneration was there, and partial regeneration and complete regeneration was less in the case of temporal flap. But 6 months, you can see there is all the ELM was regenerated, and most of the cases, 24 of the cases out of 30, it was complete regeneration. In the case of ellipsoid zone, the same thing was there. No regeneration of in most of the cases at the day 7, but most of the cases were either partial or complete regeneration at the end of the 6 months. The central macular thickness in 23 cases were more than 200 micron and 6 cases less than 200 micron. This central macular thickness was directly proportional to the vision regained. Now I am going to show you different type of cases, 2 different type of cases. In this case, macular cyst was there, total RD was there, and macular hole was there. So see, and it was my first case in 2016 or 17, and I have not done this type of case before. So see this case.
It was a case of large differences with full thickness macular hole and total city examination, large differences with this case, before calcification was done, followed by vitreoretinal. After opening of the indentum, when the knuckle was in the space, 33 gauge last one is done. After delivery, still gives the adaptive one, the level of silicon wire was injected, and second post-op period.
The third next case I'm going to show you, that is the autologous island transplant, which is simplified. How we are doing the autologous island transplant? This is a failed macular hole case. So I was doing the autologous transplant by taking out a small piece of the ILM from the periphery of this peeling, then just putting it over the macular hole. After this flow direction, now I'll show you the surgery. In this case, you can see non-closed macular hole is there. I am making an ILM flap, which I'll use as a ILM graft. Putting the flap over the hole and then fluid air exchange. At the end of the surgery, the graft was there, and you can see till the end of the surgery, the graft is perfectly placed over the macular hole. This is 4/60 pre-op. This is post-op 6/60, and you can see this is the graft and this is the regenerated tissue. Now the last one is the macular massage. What I am doing to relieve the tangential traction. This is not a typical case of macular massage. This was a very large macular hole in which I have used the nasal ILM peeling, the temporal ILM flap, and macular massage. This case is just only because just to show you how to do the macular massage. The macular massage technique was given by Dr. Alpatov in 2006, and me and Dr. Debulal has at the same time they have modified the technique with the help of the silicon tip cannula. Now you can see from periphery till the center, very gentle stroke to make the hole small on table. I am using this technique for around 500 to 600 micron hole, but this depends upon case to case. This is the technique. This is the technique where you have to relax the retina from periphery towards the center with the help of this silicon tip cannula. So the conclusion is, our aim is not to just close the hole. Our aim is the vision. And for that, we have to be the best friend of the retina. And that means we have to be very, very gentle. Any surgery you are doing, be very gentle, least iatrogenic trauma, and at the end of the day, patient will be happy. Thank you.
Hello, sir. I think that was an excellent talk, sir. And showed us a lot of various techniques for closing of the macular holes of all sizes with wonderful personal cases that you've shown. I would like a comment from each of the panelists regarding any queries or their feedback on the entire topic. Yes, ma'am.
Hi,
Avakian, ma'am.
Dr. Atul.
Yeah. Yes, ma'am. Larissa, ma'am.
First, I
Yes.
would like to congratulate you for the amazing class. And something that pulled my attention, it was the thing that you said at the end of the class. We don't have to look for only the macular closure, but we want a functional result. Because here in Brazil, we have this, I don't know, but we have seen in a lot of Congress, people trying to do like retinal transplant or using amniotic tissue to perform the closure, and then you see that you have an anatomical result, but the vision is not okay. So what I would like to ask you was about a technique that I saw at the Congress, the last Congress here at Brazil, that they performed a viscoelastic dissection of the hole to approximate the edges of the hole. And that I thought it would be a smart choice because you will not put any different kind of tissue inside the hole, but it was only a smart manner of trying to approximate the edges of the hole. If you had any experience on that, just would like to
I don't have
ask you.
any experience of that, but I have seen many people are doing that bullous detachment of the retina with the help of the 41 gauge of macula. That's with the help of the saline. But I have not tried. I have not tried. Dr. Ganesh, any experience?
Dr. Atul, no, I also would support the same thing, that it is better not to do something which is just to approximate or do something which is aggressive, and eventually closure might happen, but there may be no functional outcome in that situation. So try to close it with the minimal maneuvers as possible. Probably now we are shifting from the whole flap to a limited flap, ILM peeling and inversion of those flap. So initially we had a cauliflower like flower like thing around the fovea, but nowadays we are just doing a temporal flap to close the holes as well. So those are also having excellent results in closure and approximation. Yeah.
Sorry, but what about platelet-rich plasma? We usually use platelet-rich plasma and put it into macular hole, and we have really high visual acuity after that.
I'm not doing that also.
Okay.
Yeah, but it sounds quite good in sense that platelet-rich plasmin is something which is derived from the patient themselves. So if that can be done, we do it like autologous transplantation for pterygium cases. We do it by separation of the serum from the RBCs, and we can use that serum to put it in the hole, and can use ILM over that for a better sticking and closure of the holes as well. Yeah, Dr. Bartosz Bilinski.
I would like to congratulate you on your results. They were very good. What caught my attention was viscoelastic. I have heard about the method about adding viscoelastic after putting the flap and leaving it there so that the patient may be positioned on the back. Okay, so I have heard about this technique, and I know there is some research held to prove it successful or not. But we are fans of inverted flap technique, as you know, and we use it frequently with also very good results. So I think this is a good method. Thank you.
Right. So, Dr. Atul, what is your experience in cases of a myopic macular hole, where there is also a little excavation kind of a thing, as well as there is a large hole, which also leads kind of with a detachment also is there in such situation. So do you prefer certain techniques for such situation, or inverted ILM peeling is the choice for you? You're not audible. You're not audible clearly. Yeah.
I think Dr. is using that technique.
Sir, still not audible. Sir, still not audible, sir.
You're not audible.
No, sir. Unmute yourself and probably try again.
Here I have
Yes, sir.
unmute.
Better. Yeah,
Yeah.
better, sir.
Okay. So I'm not doing anything else. Means I'm just using this island flap technique, nothing else. I'm not doing the macular buccal. I'm not using any other thing. Means like amniotic membrane or retinal graft. No.
Right.
So
So there was a comment regarding cap technique. Can you replay that video again? The cap technique.
one second. This is how to make viscoelastic visible. We're just putting a drop of brilliant blue and shaking the syringe, you can make it visible. This is 550 micron hole. Make a flap, temporal flap with the help of the finish glue. Separate the ILM from the nerve fiber layer. Be very gentle. Put it over the hole. Now place the color viscoelastic on the temporal part. Now here so many tricks are there. One is it's not like means this surgery is not easy. Means first of all you have to understand how to do the fluid air exchange in the case of flap, because many a time we at the end of the surgery the flap is going towards the natural position. So how you are doing? You have to do the fluid air exchange from top to bottom, means from lens towards the center of towards the disc. This will decrease the turbulence. So and one more thing, when you have placed the flap over the hole and you are taking out your right hand in which you are holding the forceps, and you have to put the silicone tip cannula for the fluid air exchange. First of all, you have to pinch the infusion cannula. This will decrease cannula, and there is no turbulence and there is no movement of the flap. So while taking out the forceps from the right cannula, you have to pinch the infusion cannula. Then when you are going inside till the time, you have to keep the infusion cannula off. When you are inside, now change it from fluid to the air. Now you have to do the fluid air exchange from top to bottom. When you are doing the last part of the fluid air exchange, you have to keep your silicone tip cannula towards the disc, and you have to tilt the eye towards the disc like this, so the disc will be in the center. This leads to the flow of this viscoelastic from temporal to the disc side and ironing out the flap over the macular hole. And after this, you have to wait at least 3 minutes, because always remember, this is very important point, because there are water droplets at pars plicatum. They will go down within minutes. So it's not like this, you have done one time fluid air exchange and you will switch off and you will go and you will close the case. It's not like this. You have to put the fluid air exchange. You have done the fluid air exchange. Be there for the next 2 to 3 minutes. Take out each and every drop of the fluid and make the retina as much dry as possible. This is the whole story of the temporal ILM flap. Is it okay?
I think you have very clearly explained the technique. properly. Important point here to reiterate again would be to remove all the fluid possible from the area, so that you have a very dry kind of a place for the retina to again reattach. If you have something which is dry, it is easier to attach. It is same to as a glue. If it is wet, you may not be able to attach the two adjoining surfaces better if it is wet. So that point definitely can be taken home.
And the
There is
second,
one more question here in the chat box. How to retain the inverted ileum flap in situ while doing the fluid exchange? As the fluid need to be absorbed from near the fovea, chances to dislodge the flap always is there. So how would you retain the inverted ileum peeling? Dr. Atul first.
the same thing is put the flap over the hole. Don't think of any fluid which is inside the macular hole. When you will put the flap over the macular hole is closed, the RP is there. RP is there to absorb the fluid. RP will absorb all the fluid. In whatsoever cases I have done, in whatsoever cases I was able to see the OCT on the next day, the hole was closed. So the RP is working properly. It will take out all the fluid. So don't touch this hole. Just put the flap over the hole, tilt the eye towards the disc, do the fluid air exchange from top to bottom, and be there at least for 3 minutes to take out all the fluid. Why we are taking out all the fluid? Because when we will shift the patient from OR to the recovery room, if some fluid is there, that fluid will act as a natural force. That fluid will displace the flap from the macular hole towards its normal position. If there is no fluid, then because of the surface tension of the air, the flap will be at the same place where you have put at the end of the surgery.
Yeah, absolutely, Dr. Atul. So basically keeping your silicone tip over the disc will cause the fluid to flow from temporal to the nasal aspect, and hence it will also flatten the ileum flap during the process, and also it won't damage the ileum flap, or it may not be sucked out, as it may be reiterated here. Yes. So any more queries or questions in this regard, Dr. Vajinder?
Sir, I want to ask one question. If like we have done the surgery today, and on the next post-op day, we find that the hole is closed. Do we need to continue with the positioning of the patient, or can we ask the patient to discontinue it? If we on the next day, if hole is closed, and if the patient, can we ask the patient to discontinue the positioning? What will be the effect, sir?
Okay, first of all, understand what is the mechanism of the hole closer. The hole closer starts from inside to outside. In the gas-filled eye, the OCT is not very clear most of the time. So you are not able to take out all the radial scan, all the vertical and all the horizontal scan. You are seeing just one scan most of the time. In that scan, if the hole is closed, chances are there that some other part of the hole is open. So better to keep the face down position at least for 3 days in those patients.
Yes.
So there is another question that in the chat box, that what is any role of fibrin glue for the ileum flap and or autologous flap, and you have any experience or any personal techniques in this regard? Fibrin glue.
I think Dr. Mudit is working on this in the RDA, and I have not done any case.
Any of the panelists have any comment on this and their experiences?
No, I think it can work very well. It shouldn't be a problem, but generally it's not required as such. Basically, you can just put the ILM in place. It can be retained at its place with the help of even a visco or a fibrin glue. Either of the things should work very well. I've used visco, which works very fine as well. Yeah, Dr. Atul.
Yeah, the basic aim of this surgery is to keep the maximum visual acuity which is possible. If the patient is coming by 360 or 460, your aim should be at least 636. The patient don't want an OCT which he can put on the drawing room and show everyone that my hole is closed. Patient want to see. So do the least possible maneuver in the least iatrogenic traumatic way. For that, many things are there. Means you can use the fibrin glue, you can use the retinal tissue, you can use the amniotic membrane graft. Whatsoever you are doing, do it in the least traumatic way.
Yeah, just to add on to a very basic question of using initially lifting the flap, ILM flap. So what is the maneuver that best suit ILM pinch and peel or the finesse loop that you have demonstrated one of your surgery, or sometimes even a diamond duster?
Now I have worked with everything, but diamond duster and the finesse loop just at the cost of the surgery. After the 10-12 cases, when you have properly done. Best thing in the surgery is don't go for the shortcuts. This finesse loop is a shortcut type of thing, but the negative point of the finesse loop, it is lasting hardly for 3 or 4 cases. So it is costing additional cost for the surgery. I am very happy with the pinch and peel technique. So my favorite choice is pinch and peel technique only.
Dr. Atul, do you have a tip how to perform the 2000-degree ILM peel that you showed us? Because here we don't usually have the diamond dust or the other devices that you just mentioned, and with the forceps. I don't know if I would be able to perform such a
you're right. You are telling to make the cuts, to make a circumferential incision with the help of the forceps. This is a time-taking process. Dr. Larissa, this is a time-taking process. In that, you have to make small cuts. At least 20-25 cuts you have to give. And while removing the ILM from the nerve fiber layer, you have to join all the cuts. It's not an easy thing, but I feel after some time, it gives the same result as the finesse loop also. I don't have the video, but I can show you. But I can tell you, and you can also imagine that you are giving small. I have shown in this video, the demonstration video, in which I have given small cuts. And after the 360-degree small cut, 200-degree small cuts, I have joined all the cuts and put it over the hole. So it is not necessary that you have to get the diamond duster or the finesse loop for that surgery. But this surgery with forceps requires at least 15-20 minutes extra. And a lot of concentration, I'm telling you, because you will work very close to the arteries and the veins.
So any preferred area to start this ILM peeling? Any preferred quadrant? Or
I usually start, I am a right hand person. I usually start either in the right side, I'll start from the supranasal, in the left supratemporal area, if I am doing the 360-degree ILM peeling. So that is much better. to start slightly oblique, not vertical.
Yes, sir. So what will be the preferred tamponade, AR, SF6 or C3 effect?
Everybody is using everything, and everybody likes different thing. If you will talk about SF6, somebody will tell air is much better. If you will talk SF6, somebody will tell C3 effect is much better. So it's your choice at the end of the day. I was using C3 effect till 2013-14. After 2013, I have not used C3 effect in any of my case. SF6 works wonderfully with my hand. One thing is this, many of my friends, they are telling, Atul, you have to switch over from SF6 to air.
Yes.
But there is a bias inside me which is holding me from SF6 to air. But I am very happy with the SF6.
For example, we usually use only air tamponade without any gas. Yeah. And maybe gas it's necessary or not. Maybe we can use only air tamponade at all.
Yeah, I have listened. Dr. Zofia Navroka is also using only air from a very, very long time. And she is using air in each and every of her case. Here, many of my friends are using only air. So it's totally a surgeon's choice. What you want to use. I am happy with the gas which is inside the eye for 8 days. And because I am doing from the last 10 years, then basically I don't want to change my technique.
Yeah, and can you repeat, please, after surgery, how many hours patients need face down position?
For my patient, I usually tell patient to be in the face down position for at least 4 days. 4 days, and first day, try to be in the face down position for the 24 hours. After that, 16 to 18 hours is more than enough.
Yeah, thank you.
Because they have shown that in the upright position also, the air is filling the macular hole area, the SF6 is filling the macular hole area below the inferior arcade. So theoretically, you can go for the SF, if you are using the SF6, you can go for the upright position also. But I am not doing.
Yeah, just to add to the question there, Dr. Atul, how much vitreous would you like to remove in your cases?
Dr. Ganesh,
And whether you do endo laser, 360-degree endo laser, which is a precautionary kind of a thing in your cases.
Okay, Dr. Ganesh, I am telling you frankly, and this is 100% truth, I don't want to leave any vitreous inside the eye. Whatsoever I am doing, vitreous is our enemy. Don't leave the vitreous inside the eye. At least till aura and equator, you have to induce the PVD and then do a thorough base shaving. See before closing the case, just indent and see any holes are there or not. I am not doing any laser after the surgery.
Yeah, absolutely. So the thing is, but still, we do induce a PVD in case it's a stage 3 macular hole. And while induction of PVD, we sometimes in the lattice areas where it may inadvertently lead to break formation, or sometimes a missed a very small break in the anterior part of the eye. So that way, probably I feel it is better off when I'm trying to remove all the vitreous totally. In that case, I do laser the periphery, just 2 rows for the sake that I'm not missing out on any areas. And probably you have answered your part, whether we use gas or air. I have used air also in few of my cases, especially where the hole is very small. Uh, but generally, if the hole is large, you would like the tamponade to be there for a little longer. Very well. You need not use even 14% concentration, or 10% concentration of SF6 is sufficient, and it gets removed very early, giving early rehabilitation to the patient, early visual recovery to the patient. So that way also you can titrate whether you to use air or a SF6 and a different concentration of SF6.
So what are you using?
I that's what I'm if it's a very small macular hole, I would prefer an air, but if it's a little large, I would prefer SF6.
Oh,
There's another question, is that for each type of tamponade, what should be the ideal time for prone positioning? For air, how much? For SF6, how much? And for C3F8, how much? And how much to dilute each of the tamponade?
here is no dilution. The SF6 is 20% and C3F8 we are using 14%.
And how many days of prone positioning for each?
This is very debatable topic. How many hours, how many days to not even clear in the Ryan's also, that how many days you have to be in the face down position. So usually people are doing 3 to 5 days, but nowadays people are trying 1 day also, 2 day also. Or Vajinder is saying if the hole is closed in 1 day, then why to go for the second day face down positioning also?
Temporarily
So,
closed. Temporarily closed. If the flap is there and
I
temporarily.
think 3 to 5 days for all types of tamponade is a reasonable
yes,
thing to expect for early recovery.
in very large macular hole like 1500 micron or 2000 micron, sometimes you can use the C3F8. In that cases, you need a long-term tamponade, because how the hole closes in the flap, the hole closes because of the movement of the molar cells from the sides of the full thickness macular hole inside this flap. This will take time. You want a bridge, you want a Fevicol there, which will take time. That's why they are using C3F8 in very large macular hole.
Okay, I would like to add that this is very important what was said, and that we don't need to put ELM inside the hole. The bridge is fine. This is enough because Muller cells will migrate on this. So we don't need to force the ELM inside. We just need to be gentle with this.
Yes. The same thing I'm telling. There is no need to stuff the hole with the ILM flap, because by stuffing the hole with the ILM flap, you are just filling that area in which the movement of the photoreceptors will be there in future. So if you'll stuff the hole with the ILM flap, there will be no movement in the photoreceptor. The hole will close on OCT, but there will be no functional visual acuity.
I think we had a wonderful discussion and plenty questions and a wide variety of participants from all across the globe. Uh, and I and in any case, and thank you for all the panelists for joining us, taking out time to attend the wonderful webinar by Dr. Atul sir. I think we all learned a lot from the insights and the intricacies that he had with the thoughtfulness and the patience he does his surgeries with. I think all of us learned a lot today. I think it was like a like a summary of a textbook on macular hole, right from the origin and the treatment. So thank you, Dr. Atul sir. Thank you, Dr. Avakian, Flora. Thank you, Dr. Bartosz.
Thank you very
Thank
much.
Thank you, Dr. Larissa Yuri, for joining us. Thank you to all the ASG academic cell, Dr. Ganesh sir, Dr. Kaushik sir, Dr. Mayank sir. Thank you all the participants for this, for making this webinar a success.
Thank you. It was really exciting to take part in this discussion.
It
Thank
was a
you
Thank
very
pleasure
you.
much. I
having you.
learned a lot. Thank you, Doctor, too. You're the best.
Wonderful, Dr. Atul.
This whole the whole idea of this class is from Dr. Ganesh only. He has forced me to do this class. I was not ready because I was literally scared because so many stalwarts have given the lecture and how can I give the lecture here? But because Dr. Ganesh has told, that's why I have taken the class. The whole credit goes to Dr. Ganesh.
It was a wonderful presentation and a very practical approach to handling macular hole. I think that is what we insist on, the practical approach. So thanks a lot, Dr. Atul, for taking a wonderful session. Hope to see you in another session at the ASG Forum again. So thank you everyone for joining us. Bye
Thank
and
you
take
all.
care.
Thank you, sir. Thank you, everyone.
Thank you.
Thank you very
Bye-bye.
much.
Bye.
Thank you. Bye bye.